You wake up one morning and notice your throat feels dry, scratchy, like you slept with your mouth open, or maybe the heating system is pulling all the moisture out of the air again. You drink a glass of water. Better. You forget about it. 3 weeks later, it's still there, not dramatic, not painful. Just this persistent low-level irritation that you've now stopped noticing because it's been around long enough to become background noise. You tried a lozenge, you drank more tea, you told yourself it was allergies, or the season changing, or the stress from work finally showing up in your body the way it always does. Across town, a 48-year-old steps on the scale and blinks at the number. Down 8 pounds from last month. Not because of any diet, they haven't changed anything. If anything, they've been eating worse than usual. The explanation writes itself. Must be the stress. Must be all that walking to and from the parking garage. They make a mental note to eat better, then walk out the door. Somewhere else, a 62-year-old goes still in the bathroom and stares at the water in the toilet bowl. There's a faint pink hue. They search their memory for an explanation. Heavy lifting yesterday, maybe. Something they ate. A small vessel. They flush, and they don't think about it again for 2 weeks. And somewhere else entirely, a 35-year-old designer pulls their shirt off at the end of a long day and notices in the bathroom mirror that the mole on their shoulder looks slightly different. Different how, exactly, they couldn't say. Different enough to notice for half a second, then not different enough to do anything about it. These are not dramatic scenes. That is the point. These are ordinary mornings and ordinary bathrooms and ordinary people running ordinary internal calculations about whether something deserves their attention. Most of the time, those calculations are right. Most of the time, the cough is the air. The weight loss is the stress. The blood is nothing. The mole has always looked like that. But not always. Here's what makes cancer uniquely dangerous in its early stages. It rarely opens with a scene that demands your attention. It begins in the margins of your life. A fatigue you can almost explain. A change that feels just familiar enough to dismiss. A symptom that doesn't rise to the level of a story you'd tell someone. And by the time it does rise to that level, the window for the easiest intervention has often quietly closed. This video is built around one idea. Recognition changes outcomes. Not fear, not anxiety, not running to a doctor for every sniffle. Recognition, knowing specifically which symptoms cross the line from ordinary to worth investigating and why. The survival statistics for almost every major cancer look dramatically different when the diagnosis happens at stage I versus stage IV. That gap is not luck. It is, very often, timing. And timing is shaped by awareness. By the end of this, you'll have a working knowledge of every major warning sign. What it feels like, what's actually happening in the body, how to tell it apart from something benign, and when to act. Not to frighten you, to equip you. Unexplained weight loss, your pants fit differently. Not dramatically, no one would notice. But you notice, in the quiet way, you notice things about your own body that you would never think to mention to anyone. They're looser at the waist. A belt you stopped using 2 years ago fits again. You're not complaining. You've been meaning to lose a few pounds. You rack your brain for what changed. Maybe you've been eating a little less at lunch. Maybe the walking adds up. You don't overthink it. You call it a win and move on. But over the next few weeks, it keeps going. Another 5 pounds. Then 3 more. You haven't changed anything. And now there's something else. You're just not that hungry. You used to eat breakfast without thinking. Now the idea of it doesn't appeal. You have coffee and keep moving. Clinically, this pattern has a name and a threshold. Unexplained weight loss is defined as losing more than 5% of your baseline body weight within a 6 to 12-month window, without deliberate dietary change or increased exercise. For a 180-pound person, that's 9 pounds. For someone at 150, it's 7.5. Numbers that could disappear entirely into the ordinary variation of daily life, especially if you're not tracking. What's actually happening in cancer-related weight loss is not a simple reduction in appetite. It's a metabolic process called cachexia. And the key thing about cachexia is that it cannot be reversed just by eating more. The tumor, and the immune system's inflammatory response to it, floods the bloodstream with chemical signals, specifically proteins called TNF-alpha, interleukin-6, and interleukin-1. These cytokines act on skeletal muscle through a cellular degradation pathway called the ubiquitin proteasome system, breaking down muscle tissue even when the person is consuming adequate calories. They act on fat stores, accelerating lipolysis, the breakdown of adipose tissue. They act on the hypothalamus, suppressing appetite centrally. And they drive the body into a hypermetabolic state where mitochondria actually waste energy as heat rather than storing it as ATP. The result: a body losing mass from multiple fronts simultaneously, driven by a process that has nothing to do with caloric deficit. What makes this different from ordinary weight loss is exactly that mechanism. If you eat less, your body burns fat for fuel. That is the intended system. Cachexia dismantles muscle even when you're eating adequately, and it keeps running even when you try to outpace it nutritionally. It's the body burning the house for warmth. Unexplained weight loss is most strongly associated with cancers of the stomach, pancreas, lung, and colon, but it can accompany malignancy across nearly every organ system. The concerning detail is that by the time cachexia is clearly measurable, the process has typically been running for weeks or months. Constant fatigue that doesn't improve. You slept 8 hours. You know you did. You checked the time before closing your eyes and again when you woke up. 8 full hours. And yet here you are, 45 minutes into the morning, sitting at the kitchen table with a coffee going cold beside you, feeling like you haven't slept at all. You've been like this for weeks. Not tired in the way that follows a hard day, where you know the cause and you know the cure. Tired in a way that doesn't have an obvious origin and doesn't respond to rest. You canceled plans last weekend. You've been less present in conversations, drifting. Your partner asked if you were okay, and you said yes, because what else would you say? You don't have a reason. Malignancy-associated fatigue is a clinically distinct state. It is not tiredness after exertion. It is not the reasonable heaviness at the end of a long week. It is a persistent, disproportionate, overwhelming exhaustion that exists independent of activity level and is unresponsive to sleep. The mechanisms driving it are multiple and compounding. Chronic elevation of inflammatory cytokines, IL-6, TNF-alpha, IL-1 beta, directly disrupts mitochondrial function at the cellular level and interferes with the neuroendocrine pathways that regulate energy and alertness. In blood cancers specifically, leukemia and lymphoma and multiple myeloma infiltrate the bone marrow, disrupting hematopoiesis, the production of blood cells. The result is progressive anemia. Your red blood cell count drops. Your blood carries less oxygen per liter. Climbing a flight of stairs becomes genuinely difficult in a way you cannot fully explain. Because the limitation isn't muscular, it's oxygenation. And then there's the metabolic demand of the tumor itself. Rapidly dividing cancer cells consume glucose and amino acids at an accelerated rate, competing with normal tissue for the body's energy reserves and, at the cellular level, winning. What makes this different from burnout, the diagnosis most people give themselves, is a cluster of distinguishing features. Burnout typically improves with genuine rest, a change of environment, or a reduction in stressors. Cancer-related fatigue does not improve with rest. It doesn't have a weekend, it doesn't respond to a vacation, and it usually arrives alongside other signals that burnout doesn't produce. Weight loss, persistent low-grade fever, night sweats, a general dimming of appetite. When fatigue comes with companions, the company it keeps matters enormously. A persistent fever or night sweats. You wake up at 2 a.m. and the sheets are soaked through. Not slightly damp, genuinely wet, in the way that means you need to change everything before you can go back to sleep. You check your temperature. Normal. You change your shirt, kick off the covers, and eventually fall back asleep. In the morning, you feel fine. You assume it was just a hot night, or too many blankets, or your body doing whatever bodies do. It doesn't happen again for 3 nights. Then it happens again. And twice the week after that, in hematology, drenching night sweats, the kind severe enough to require a change of clothing or bedding, combined with recurrent, unexplained fever above 38 degrees Celsius, are formally categorized as B symptoms. This is not a casual label. In leukemias and lymphomas, B symptoms carry diagnostic and prognostic weight. Their presence shifts both the staging and the treatment approach. What's actually happening is this. Malignant cells, particularly in Hodgkin lymphoma, specifically a cell type called Reed-Sternberg cells, release pyrogenic cytokines into the bloodstream. IL-6, IL-1, and TNF-alpha circulate to the preoptic area of the anterior hypothalamus and stimulate the synthesis of prostaglandin E2. That molecule raises the hypothalamic thermoregulatory set point, your body's internal thermostat. Autonomic responses kick in. Cutaneous vasoconstriction, shivering, increased metabolic heat production. Core temperature rises, then the cytokine release fluctuates. The set point drops suddenly. The body has to shed the accumulated heat as fast as possible, and the only mechanism available is profuse sweating, diaphoresis. This is the night sweat, not a response to being too warm in bed, but to a rapid shift in the hypothalamic set point driven by intermittent tumor-derived signals. What makes this different from ordinary night sweats is the pattern and the severity. Hot flashes related to hormonal changes present differently, briefer, with a flushing sensation, typically without fully drenching the sheets. Infection-driven fever follows a cause. You're sick, the fever tracks with your illness, and it resolves when the infection does. Neoplastic fever cycles without an identifiable trigger. A rare but characteristic pattern called Pell-Ebstein fever, seen in Hodgkin lymphoma, alternates high-grade fevers lasting 1 to 2 weeks with afebrile periods of similar duration. A thermal rhythm with no infectious explanation. A fever with no source is unusual. One that keeps returning, for no reason, is something else entirely. Seared cough or hoarseness. You've had a cough for 6 weeks. You've counted. 6 weeks of this low, dry catch in your throat that interrupts conversations, wakes you at 3 a.m., and refuses to follow the expected trajectory of getting better and then going away. You've tried 2 different medicines. You've elevated your pillow. Your doctor mentioned postnasal drip and recommended antihistamines. You tried them, the cough continued, and now your voice sounds different. Not dramatically, just slightly rougher than it used to be. A colleague asked if you were coming down with something. You said maybe. A cough that persists beyond 3 weeks, without a clear respiratory cause, and especially one that changes character, deepens, or is accompanied by blood-streaked mucus, requires a formal clinical evaluation. Full stop. What's actually happening in lung cancer is mechanical. A tumor growing inside or adjacent to a bronchus creates persistent local irritation. The body's protective reflex is to cough, but the trigger isn't clearing, it's growing. In some cases, the tumor produces partial bronchial obstruction, which generates a localized wheeze audible on one side only during auscultation, a finding that points to blockage rather than generalized airway disease like asthma. Hoarseness has a different and highly specific mechanism. The recurrent laryngeal nerve runs an unusually long path through the chest, looping around the aortic arch on the left side, before ascending back to the vocal cords. A tumor near the left hilum, the mediastinum, or in the path of this nerve can compress or infiltrate it, causing one vocal cord to stop functioning properly. The result is a voice that sounds rough, breathy, or changed, not because of anything wrong in the throat itself, but because of a nerve compression whose origin is in the chest. What makes this different from a post-viral cough or laryngitis is the direction of travel. A respiratory infection improves. It has a peak and a resolution. A cough still present at week 8, with no improvement and no clear viral origin, is on a different trajectory. Hoarseness lasting beyond 3 weeks in someone over 50 with any history of tobacco or significant alcohol use is a clinical flag requiring endoscopic examination of the larynx. And the addendum that should be said plainly: non-smokers develop lung cancer. The adenocarcinoma subtype in particular arises in the peripheral lung and frequently affects people without any smoking history at all. A persistent, unexplained cough in a non-smoker is not a reason for reassurance. It is equally worth pursuing. Shortness of breath. You used to take the stairs without thinking. 2 flights, no issue. Now you find yourself pausing at the 2nd floor landing, catching your breath in a way that feels disproportionate to what you just did. You've written it off as being out of shape. You've been meaning to exercise more. You'll get back to it. But it's been 3 months, and it's not improving with time the way deconditioning typically does. There's a tightness in your chest sometimes, even at rest. A sense of not being able to take a full breath. Not pain, just a ceiling on inhalation that wasn't there before. New onset or progressively worsening shortness of breath, without a clear cardiovascular or respiratory diagnosis, requires investigation. The vast majority of causes are benign: asthma, COPD, anemia, deconditioning, anxiety. But intrathoracic malignancies can produce dyspnea through several distinct mechanisms, each with its own imaging signature: airway obstruction. A large primary lung tumor growing near a major bronchus can cause segmental lung collapse, obstructive atelectasis, when the airway is blocked. The affected portion of the lung cannot inflate, and the remaining tissue compensates imperfectly. Pleural effusion. Tumors spreading to the pleura can obstruct local lymphatic drainage, causing fluid to accumulate in the pleural space. As it builds, it compresses the lung from the outside, physically limiting its capacity to expand with each breath. A moderate pleural effusion produces a progressive breathlessness that worsens with exertion and eventually intrudes at rest. Mediastinal compression. Bulky masses in the central chest compartment can compress the trachea directly or obstruct venous return through the superior vena cava. Superior vena cava syndrome presents with progressive dyspnea, facial and neck swelling, and dilated chest wall veins, a medical urgency that requires prompt imaging and intervention. Breathlessness that is new, progressive, and doesn't have an explanation is your body's least ambiguous signal that something in the cardiorespiratory system is not working correctly. The cause may be entirely benign. Finding out which it is requires imaging, not patience, blood where it shouldn't be. You notice it. In the toilet, on the tissue, in the sink after you cough. And in the seconds that follow. Your brain goes to work, building the most reassuring explanation available. It was the lifting. It was the spicy food. A small vessel. One time means nothing. But it happens again. And now the explanation is slightly thinner. Unexplained bleeding from any bodily orifice is one of the strongest clinical predictors of underlying malignancy. Not the most common cause. Benign conditions explain bleeding far more often than cancer does. But among all cancer warning signs, visible blood is both the least ambiguous and the most consistently rationalized away. Both things are simultaneously true. Blood in the stool can appear as bright red on tissue or coating the stool, typically indicating a lower colorectal or rectal source, or as dark, tarry, malodorous stool called melena, which suggests bleeding higher in the digestive tract from the stomach or the right-sided colon. Attributing rectal bleeding to hemorrhoids without a clinical examination is one of the most common and consequential delays in colorectal cancer diagnosis. Hemorrhoids are common, so is colorectal cancer. The only way to know which one you're dealing with is to look. Blood in the urine requires particular attention. Painless hematuria, whether visible or detected only under a microscope, is a cardinal sign of bladder cancer. It can appear once and then disappear for weeks before returning. This intermittent pattern is exactly what creates the false impression that it resolved. For anyone over 35, even a single episode of unexplained hematuria requires diagnostic workup, cystoscopy, and renal imaging as a minimum to rule out urothelial malignancy, coughing blood, even blood-streaked sputum that you might question whether you actually saw, warrants chest imaging. Vomiting blood requires urgent upper endoscopy. Unexpected vaginal bleeding between cycles, after intercourse, or after menopause always requires formal evaluation. Postmenopausal vaginal bleeding, defined as any vaginal bleeding more than 12 months after menstruation has fully stopped, is a classic presenting sign of endometrial or cervical cancer. It should never be attributed to dryness or minor trauma without a transvaginal ultrasound and endometrial biopsy. The word painless recurs repeatedly in oncology when describing cancer-related bleeding. This matters because pain is what prompts people to act. Painless bleeding feels less urgent. It is easier to dismiss. The absence of pain is not the absence of pathology. Changes in bowel habits. You're not sure exactly when things shifted. A few months ago, maybe, you've been more constipated than usual. Or the opposite, looser stools more often, the kind that used to be unusual for you, but have gradually become the new normal. You cannot remember the last time your digestion felt like it did a year ago. There's also this feeling after you go that you haven't quite finished. Like the signal is still there even when there's nothing left. You've told yourself it's diet, or stress, or the fact that you've been sitting more PSERD changes in bowel habits, constipation, chronic diarrhea, narrowing of the stool caliber, or a constant sensation of incomplete rectal evacuation called tenesmus, lasting more than 4 weeks require medical evaluation. Not assumption and dietary adjustments. Medical evaluation. The presentation of colorectal cancer is heavily shaped by anatomy, specifically by where in the colon the tumor sits. Left-sided colon cancers in the descending colon, the sigmoid, and the rectum develop in a narrower tube carrying more solid stool. These tumors tend to grow circumferentially, wrapping around the bowel wall in a ring-like pattern. As the ring tightens over months, the passage narrows progressively. The symptoms are obstructive, increasing constipation, stools that become thinner and thinner until they're ribbon-like, painful straining, and that persistent sensation that the bowel hasn't fully emptied. Right-sided colon cancers in the cecum and ascending colon develop in a wider, more distensible section of bowel carrying semi-liquid stool. These tumors typically grow as flat, bleeding lesions rather than obstructing masses. Because the passage is wide enough to accommodate them for longer, obstruction is a late sign. What they cause first is invisible, occult bleeding into the stool that you cannot see, gradual iron depletion, anemia that develops over months and presents as unexplained fatigue, pallor, and breathlessness on exertion. All the right symptoms, pointing to entirely the wrong organ system. The clinical implication is significant. Right-sided colorectal cancer is frequently diagnosed later than left-sided, and for a straightforward reason. The bowel itself behaves normally for longer, and the symptoms it generates are hematological, not gastrointestinal. Changes in urination. Something has shifted in how you use the bathroom. You're going more often, once in the night, sometimes twice, which didn't used to happen. There's an urgency to it that catches you off guard. And once or twice, a faint burning sensation that came and went before you could decide whether it was real. You assume it's an infection. You drink more water. You wait. It doesn't fully clear. Lower urinary tract symptoms, frequency, urgency, dysuria, difficulty starting a stream, or the feeling of incomplete emptying are common and most often benign. In younger people, urinary tract infections are the typical cause. In older men, benign prostatic hyperplasia, the non-cancerous prostate enlargement that comes with age, compresses the urethra and produces obstructive symptoms that are nearly indistinguishable from early prostate cancer. The symptoms are identical. Distinguishing them requires a digital rectal exam and a PSA test, not a presumption that it's one or the other. Blood in the urine is the symptom in this category that crosses from common to urgent. Painless hematuria, visible or microscopic, is a cardinal sign of bladder cancer. It can appear once, disappear for weeks, and return. This intermittent pattern is exactly what creates the false impression of resolution. For anyone over 35, a single episode of unexplained hematuria, even one that appeared once and never returned, requires formal urological investigation, cystoscopy and renal imaging at minimum, recurrent urinary tract infections that keep returning, or that fail to fully clear with appropriate antibiotic treatment, also warrant further evaluation. Persistent infection can sometimes coexist with a structural abnormality or with a bladder cancer that is generating the right conditions for bacterial colonization, difficulty swallowing. You notice it first with bread. Something about the texture, it doesn't quite go down the way it used to. You chew more carefully, take a larger sip of water, and it passes. Barely worth noting, a few weeks later, it's dense meat. Then pasta. You've started unconsciously choosing softer foods, cutting things into smaller pieces, reaching for the water glass more often during meals. You haven't named this as a symptom. You've simply adapted around it without registering that adaptation as information. Then one evening, you try to swallow and feel a distinct, uncomfortable resistance. A brief sensation of something not moving the way it should. Progressive dysphagia, difficulty swallowing, that begins with solid foods and gradually extends to softer foods, then potentially to liquids, is one of the most clinically significant symptoms in this entire list. Not because it is dramatic, but because of what the progression itself communicates. Solids to liquids is the hallmark of mechanical obstruction, a physical narrowing of the esophagus that worsens over time. In esophageal cancer, a tumor growing along the esophageal wall gradually reduces the diameter of the passage. Solids cannot navigate it first, then softer foods, then liquids. The trajectory is always inward, always narrowing. This pattern is clinically distinct from dysmotility disorders, conditions like achalasia or esophageal spasm, where neuromuscular dysfunction causes difficulty with both solids and liquids from the beginning, and where the symptoms are often intermittent and positional rather than relentlessly progressive. The weight loss that accompanies esophageal cancer is driven by two forces simultaneously: the cachexia of malignancy running in the background, and the simple mechanical reality that eating becomes difficult and sometimes painful. People eat less without consciously deciding to. The caloric deficit compounds. By the time the swallowing problem is dramatic enough to force a medical visit, it has usually been building for months. Early-stage esophageal cancer has good outcomes with intervention. Progressive dysphagia, worsening over weeks, not a one-time event, is not something to adapt around. It is something to investigate urgently. A lump anywhere on the body, you find it in the shower. A small firmness just below the skin that wasn't there before, or that you never noticed before, which is its own unsettling question. It doesn't hurt when you press it. It moves slightly, but not freely. It's the size of a small marble with edges that are harder to define than you'd expect. You press it once or twice, get out of the shower, and don't think about it for a month. A month later, it's still there. And it might be slightly larger. The majority of palpable lumps are benign. Cysts, lipomas, fibroadenomas, reactive lymph nodes responding to a recent infection. This is statistically true and genuinely worth holding on to. But specific physical characteristics meaningfully separate a lump worth watching from one that warrants prompt evaluation. Malignant lumps tend to be hard. Not rubbery or soft, but dense and firm to the touch. They tend to be fixed to the underlying tissue or to the overlying skin, meaning they resist movement when pushed rather than sliding freely beneath the surface. Their borders are irregular or poorly defined rather than clean and smooth. And they grow, gradually, usually silently, but consistently in one direction. Benign lumps behave differently. A soft, mobile, tender node that appeared after a cold or a skin infection, and that resolves within 3 to 4 weeks, is almost certainly reactive. Tenderness in a lymph node is often a reassuring sign, because rapid capsular stretching from infection causes pain. Malignant nodes grow slowly and are typically painless. The anatomical locations worth the most attention: any new, hard, fixed mass in the breast, persistent lymphadenopathy in the neck that hasn't resolved within 3 to 4 weeks without an obvious infectious cause, any hard, painless lump or irregularity on a testicle. Testicular cancer primarily affects younger men and is highly curable when caught early, and the exam takes 30 seconds. Enlarged, firm, non-tender nodes in the armpit or groin that have been present for more than a month. Pain is not a reliable signal either way. The absence of pain does not make a lump safer. It makes it easier to ignore. Those are different things. Changes in the skin. You've had the same moles your whole life. You know where they are in the way you know the layout of your own bedroom, automatically, without having to look, from years of it being true. This one on your shoulder, that one behind your knee. 3 on your left forearm, clustered close together, but lately, one of them looks different. Not dramatically, just not quite the same. The edges aren't as clean. You could swear part of it is darker than it was before, or darker on one side than the other. You've been looking at it for 2 weeks, trying to decide if you're imagining it. The clinical tool for evaluating pigmented lesions is the ABCDE rule, and it's worth knowing in full. Asymmetry: one half of the lesion doesn't mirror the other. Border: the edge is ragged, notched, scalloped, or blurred rather than smooth and cleanly defined. Color: multiple shades within the same lesion, brown, black, red, white, or blue, rather than uniform pigmentation. Diameter: traditionally flagged at 6 millimeters or larger, roughly the size of a pencil eraser, though smaller lesions are not thereby cleared. Evolving: any documented change over weeks or months in size, shape, color, or texture, or the development of new symptoms like bleeding, itching, or crusting. What's happening in melanoma is uncontrolled proliferation of melanocytes, the pigment-producing cells, initially within the epidermis, then vertically downward into the dermis and potentially the bloodstream. Each letter of the ABCDE criteria maps a biological event. Asymmetry and irregular borders reflect non-uniform, uncontrolled growth. Color variation reflects heterogeneous cell populations within the tumor mass. Evolution, the E that matters most to most dermatologists, reflects active change. A mole that is changing is behaving in a way moles should not. For nodular melanoma, a faster-growing subtype that can appear symmetrical and raised and fail the classic ABCDE criteria, there's an extended framework, EFG, elevated above the skin surface, firm to the touch, growing rapidly over a period of weeks. Any fast-growing raised cutaneous nodule, regardless of apparent symmetry, deserves evaluation. One additional concept: the ugly duckling rule. A mole that simply looks unlike all your other moles, that stands out from your personal pattern, deserves a dermatologist's eyes, regardless of whether it meets any specific criterion. Your other moles are your baseline. The one that doesn't fit is the one to watch. Sores that never heal. There's been a raw spot on the inside of your lip for nearly a month. You first noticed it after biting the same area twice in 1 week. You assumed it was a canker sore, the kind that shows up when you're run down or stressed, and you waited for it to go away the way those always do. But it's still there, possibly slightly larger. When you run your tongue along the edge of it, the border feels harder than it should. More defined, There's a raised, firmer quality to the rim that isn't how a canker sore heals. A wound or ulcer on the skin or oral mucosa that fails to heal within 2 to 3 weeks is a primary warning sign of localized malignancy. This timeline matters because benign ulcers have a reliable biology. They peak within a few days, then resolve. They respond to time and often to topical treatment. A malignant ulcer doesn't obey this timeline. It holds its position, it may enlarge. It develops a firm indurated border, a hardening at the edges produced by infiltrating tumor cells. The center may crust or develop a keratinized, crater-like quality. It resists treatment. In the oral cavity, persistent non-healing sores are most strongly associated with squamous cell carcinoma, particularly in people with a history of chronic tobacco use or heavy alcohol consumption. But oral cancers occur without either of those risk factors. The mouth, tongue, gum line, floor of the mouth, soft palate, and lips are all surfaces that can harbor malignant lesions, and almost all of them are visible during a simple 30-second self-examination. On the skin, non-healing lesions larger than 1 centimeter on chronically sun-exposed surfaces, the face, scalp, backs of the hands, forearms, are suspicious for cutaneous squamous cell carcinoma. These often begin as a rough, scaly patch that gets gradually larger and eventually breaks down into an ulcer. Healing is one of the body's most automatic functions. When a wound actively refuses to heal for weeks, and when it grows harder and larger rather than smaller and softer, it has stopped being a wound. It is something else, pacillard pain without explanation. It's been there for 2 months. Not excruciating, more of a constant, dull presence in your lower back, left side, just above the hip. Not the kind of pain that follows a specific movement or responds to stretching. It's there when you sit. It's there when you lie down. It's actually worse at night, which is the opposite of what you'd expect from a muscle problem. You've tried ibuprofen, a heating pad, a new mattress pad. None of it has changed anything pacillard. Unexplained pain lasting for weeks without a clear musculoskeletal or infectious cause, and particularly pain that is worse at night or at rest rather than with activity, warrants diagnostic investigation. Pain that worsens at night is a red flag in oncology, specifically because it behaves oppositely to mechanical pain. A strained muscle or herniated disc is aggravated by loading and movement and relieved by lying down. Cancer-related bone pain, particularly from metastatic spread, tends to worsen at night and at rest when both inflammatory cytokine activity follows its diurnal rhythm and when the distraction of daily activity is gone. Bone is one of the most common sites for secondary metastasis, receiving deposits particularly from breast, lung, prostate, kidney, and thyroid primaries. 2 types of bony involvement occur. Osteolytic metastases stimulate osteoclasts to break down bone, creating structurally hollow regions that weaken integrity and cause a characteristic dull, gnawing ache that can progress to sudden sharp pain if a pathological fracture occurs. Osteoblastic metastases stimulate the production of dense but disorganized new bone that is also fragile and painful under load. Pacillard back pain deserves a specific note. Spinal metastases carry a risk of cord compression, a medical emergency. The warning signs follow a trajectory. Back pain that worsens steadily, then bilateral leg weakness, then sensory deficits in the legs and saddle region, then loss of bowel or bladder control. This is not a symptom to manage with over-the-counter analgesia. Unexplained persistent headaches, pelvic pain without gynecological explanation, and joint pain without a history of arthritis all belong in the same category. Pain that has no precipitating event, no trajectory toward resolution, and no response to standard treatment. Brief changes beyond a lump. You're in the shower, arm raised, and you glance down and notice the skin over one section of your breast looks different. Not all of it. A patch about the size of a tangerine, where the surface is dimpled and puckered in a way that resembles the rind of an orange. Small depressions at the hair follicles, surrounded by slightly thickened, swollen skin. You haven't felt a lump. Nothing hard underneath. Just this change on the surface. What you're describing is called peau d'orange, orange peel skin, and it is the hallmark presentation of inflammatory breast cancer, one of the most aggressive forms of the disease. It frequently presents without any palpable mass at all. The mechanism is not a growing tumor, pushing outward from inside, but tumor cells invading and physically blocking the dermal lymphatic vessels. Lymphatic obstruction causes fluid to accumulate in the skin. The surrounding tissue swells. The hair follicles, anchored from below, get pulled inward relative to the edematous surrounding surface, creating the dimpled texture. The area may be red, warm, and tender in a way that looks remarkably and dangerously like a breast infection. This last point is one of the most clinically important in this entire video. Inflammatory breast cancer is routinely misdiagnosed as mastitis, especially in postpartum women. If presumed mastitis in any individual, including men, because breast cancer occurs in male anatomy too, does not show clear clinical improvement within 1 week of appropriate antibiotic therapy, the next step must be biopsy, not a second antibiotic course. Biopsy other breast changes that deserve clinical attention. A nipple that has turned inward when it previously faced outward, indicating a tumor infiltrating and shortening the underlying lactiferous ducts. Spontaneous discharge from a single duct, particularly clear or bloody rather than milky. Persistent unilateral redness, thickening, or pain that doesn't fit an infection pattern. Public awareness campaigns have successfully spread the message about breast lumps. These other signs remain significantly under-recognized. Unusual swelling. Your shirt collar has been feeling tighter on the left side for about 6 weeks. When you press along your neck, there's a firmness there that wasn't present before, not dramatic, not painful, just a persistent thickening that seems to have settled in. No preceding sore throat, no ear pain, no recent cold. 6 weeks is a long time for a lymph node to be enlarged without an explanation. Peace alert. Unexplained lymphadenopathy, swelling of the lymph nodes lasting beyond 3 to 4 weeks without an obvious local infection, is a significant clinical finding. In lymphoma, enlarged lymph nodes are frequently the primary presenting sign, and they have exactly these characteristics: firm, non-tender, persistent, with no infectious cause. In solid tumor cancers, regional lymphadenopathy indicates spread into the lymphatic system. Supraclavicular nodes, those situated just above the collarbone, carry a particularly strong clinical association with intrathoracic or intra-abdominal malignancy. A palpable supraclavicular node in an adult without an obvious infection is a finding that should prompt imaging of both the chest and abdomen, not watchful waiting. Rapid abdominal swelling, a progressive increase in girth over weeks without dietary explanation, can indicate ascites, fluid accumulating in the peritoneal cavity. In oncology, ascites is associated with peritoneal spread from ovarian, gastric, and colorectal primaries, or with hepatic venous obstruction from liver involvement. The fluid builds gradually and is often painless in its early stages, which is exactly what allows it to progress unnoticed under loose clothing. Rapid, asymmetric leg swelling, one leg significantly larger than the other, developing over days, can indicate a deep vein thrombosis. DVTs in people without obvious precipitating factors, no recent surgery, no prolonged immobility, no hormonal medication, carry a known association with occult malignancy. Tumors secrete procoagulant factors that shift the blood toward thrombosis. The clinical association has an eponym, Trousseau's sign of malignancy, and a first unexplained DVT in someone without risk factors is worth investigating for an underlying cancer, pellucid headaches, or neurological changes. You've always been someone who gets the occasional headache. Manageable. You take something, it passes. But these have been different for 2 months, more frequent, more insistent, harder to shake. They're worst in the morning, on wake, and ease somewhat as the day goes on. And last week, during a meeting, your vision did something strange. A blurring in the right peripheral field that lasted about 30 seconds and then vanished. You almost mentioned it to someone. You decided not to. Most headaches are benign. Primary headache disorders like tension headaches and migraines vastly outnumber intracranial causes, and this context matters. But a specific cluster of features distinguishes a headache driven by raised intracranial pressure from the ordinary kind. A diurnal pattern, headaches characteristically worst on waking in the morning, then easing throughout the day, reflects impaired cerebral venous drainage during overnight recumbency. Intracranial pressure rises while you sleep. The headache is what you feel on waking. Valsalva exacerbation, headaches triggered or sharply worsened by coughing, sneezing, bending forward, or straining, reflects a pressure-responsive headache. These physical actions briefly spike intracranial pressure. If the headache responds, it's telling you something about the pressure inside the skull. Associated neurological signs move this from concerning to urgent. Unexplained projectile vomiting without preceding nausea. A classic sign of raised intracranial pressure. Progressive focal weakness or numbness on one side of the body. Personality or behavioral changes. which are often noticed by partners and family members before the person themselves. This pattern is particularly associated with frontal lobe lesions, affecting executive function and emotional regulation. Visual field defects like the brief peripheral event described above. A first-ever seizure in an adult with no prior seizure history. The brain occupies a fixed space. What grows inside it must borrow room from elsewhere. Neurological signs are the direct evidence of that displacement. A function moved, a pathway compressed, a connection interrupted. When several of those signs accumulate together, the pattern is not coincidence. When several mild symptoms happen together, you've been tired for months. Not incapacitated, just running lower than usual. Your appetite has been off. You've lost about 7 pounds without trying. There's been a dry, persistent cough you keep meaning to get seen. And you've been sweating more at night than is normal for you. Each of those, taken alone, has a plausible explanation. The fatigue is stress. The appetite is the fatigue. The weight is the appetite. The cough is the air. The night sweats are the bedroom temperature. But they've all been there simultaneously for 2 months. Individual mild symptoms below the standard threshold for urgent referral can aggregate into a pattern that crosses that threshold. The co-occurrence of fatigue, unexplained weight loss, persistent cough, night sweats, and appetite loss, sustained over weeks, is a systemic constellation, not a coincidental collision of minor complaints. It suggests that something is affecting the body broadly and constitutionally, which is the presentation profile of disseminated or advanced malignancy. The NHS developed rapid diagnostic centers, also called non-site-specific symptom services, specifically to capture this presentation. These fast-track pathways exist for patients whose symptom combination doesn't fit a single organ urgent referral channel, but whose overall picture or whose clinician's instinct warrants accelerated investigation, the self-audit. If you have 2 or more unexplained symptoms that have been present for more than 3 to 4 weeks, without a diagnosis that accounts for them, that combination belongs in a clinical conversation. Not to confirm your worst fear, to activate the diagnostic process that can rule it out properly or find it early enough to act. When should you actually see a doctor? The honest question after everything in this video is not whether to worry. It's when to act. Here are the evidence-based thresholds. Any unexplained symptom that persists, worsens, or returns over 3 to 4 weeks without a clear cause belongs in a clinical conversation. A change in bowel habits lasting more than 4 weeks. Abdominal bloating occurring more than 12 times a month in women over 50. This specifically warrants a CA-125 test and pelvic ultrasound as a first-line ovarian cancer screen. Any new hard, fixed, or growing lump, regardless of whether it causes pain. Any unexplained bleeding in the stool or urine, from the respiratory tract, from the upper gastrointestinal tract, or from the reproductive system after menopause. Unintentional weight loss exceeding 5% of body weight within 6 months. Persistent, unexplained pain that is not responding to standard analgesia and has been present for weeks without a clear diagnosis. One psychological reality deserves to be named directly. Fear is one of the most consistently documented barriers to seeking medical evaluation. The fear of what might be found, the fear of medical environments, the fear of wasting a physician's time, of overreacting, of being wrong. These fears are normal, well-documented, and they cost people the window in which the simplest interventions are available. The medical reality is that clinicians are trained to work with diagnostic uncertainty. An initial normal result does not close a case. Sound clinical practice involves safety netting, which means explicitly arranging follow-up if symptoms persist or change. You do not need a self-diagnosis to make an appointment. You need a symptom that hasn't resolved. Getting checked is not the same as deciding you have cancer. It is the decision to find out. And only one of those gives you options. Final thoughts. Early attention saves lives. The numbers deserve a moment. Female breast cancer, 5-year survival above 99% at localized stage. At distant metastatic stage, 27 to 30%. Colon cancer, 91% at localized stage, 13% at stage IV. Melanoma, nearly 100% caught locally, 15 to 35% after it spreads to distant sites. Kidney cancer, 93% at localized stage, 12% at metastatic stage. Rectal cancer, 90% at early disease, 18% at stage IV. These are not abstract statistics. They are a map of what timing does to outcomes. The difference between a localized diagnosis and a distant metastatic one is not primarily genetic fate. It is frequently months. The months when symptoms were present, mild, and rationalized away, the body communicates in a language that becomes more urgent the longer it goes unanswered. Most of what it says is benign, temporary, or explainable. But the signals in this video are the ones where the language shifts, where the symptom has stopped being background noise and started being a message that deserves a response. Recognize the signals. Act on them early. That is where the difference lives. Don't ignore your body. It often whispers before it screams.